So let's start today as we get started with a question. How many of you here have been on a mission trip, are interested in a mission trip, are planning a mission trip at some point in the future? Raise your hands. Been out of the country? Okay. That's why you're here. Everybody here is wanting to know, wanting to think about, or has been participating in medical missions. And our goal, hopefully by the time we're done today, is to talk about a couple of things that might be some data, some survey data that will prepare you for that. So, but before we start, let's get something out of the way. Get out your checkbox. I'm an old, cranky guy, former hospital administrator, opinionated, no right to tell you what to do. So you check all those boxes. So we're okay. My name's Andy Mayo. I'm the CEO of MBF. But I'm not going to spend my time today telling you about how wonderful MBF is. We're going to talk specifically about some survey data. And hopefully by the time we're done, the Holy Spirit, God will be speaking to you and getting you motivated to get out and get going. So before we start, before we talk about the agenda, I want to take a step back and say, what is the urgency around medical missions? Why should you care? I mean, you here in the room, you're planning on that, but is there urgency? And what I want to tell you is there is more urgency to medical missions outside the United States than you might have even thought about. Let's just look at Africa. Major change is not just coming, it's already underway. If you think about statistics, if you look at statistics in Africa right now, historically, about 50% of all health care in Africa has been provided by faith-based organizations. But I'm here to tell you the church is in danger of losing its platform for sharing the gospel. It's in danger of losing its platform for compassion. And you say, well, how does that work? Well, let's take a step back. Let me give you some statistics. Let's just look at the United States. Let me give you a few statistics from the United States that might help inform us as to what's happening in Africa in the next 10 years. Well, first of all, there's the age wave, okay? Say the age wave. Well, in the United States, from 1960 to 2015, there was a 280% increase of the people over 65. So today, people over 65 are 14% of the population, right? But they consume 40% of all hospital admissions and 50% of all hospital costs. So if you look at developing countries as they develop, what happens? They age. It's the pig and the python. You know, the python eats the pig and then it goes through. That's what's going to happen in the next 10 to 20 years as they develop. Here's a test. How many of you know, what was the budget of Medicare in 1964? Yeah, trick question. It was zero. Medicare was signed in 1965. But in 1965, the Medicare budget was $3.1 billion. Today, it is $750 billion and consumes 15% of all the U.S. budget. So you think of all of our governmental budget, 15% of that goes just for Medicare, for people over the age of 65. So again, you think about that wave that's coming. So you have all these people that are over 65 that are getting older. Just think about those history. Since 1981, between 81 and 2015, we went from 19 million surgeries to 27 million surgeries, a 42% increase. Outpatient visits went from in 1981, went from 200 million to 750 million today, outpatient visits. That's a 250% increase. If you look at the hospital industry in that period of time, since 81, there are 1,000 fewer hospitals. There's 22% less beds, and 77% of all community hospitals are now in a system. They can't survive alone. And one last change, let's talk about clinical care. In 1966, 16% of all nurses were BSNs. The goal is by 2020, they want 80% of all nurses to be BSNs. So if we could get in a time capsule and go back to 1965 and sit down with the Christian hospitals at that time and say, here's what the next 20, the next 40 years are going to look like, what would we counsel them with? The United States today, historically, if you go back to 1900, 65% of all the health care in the United States was church-based, church-owned organizations. Today it's down to 13%, and most of that is the Catholic hospital systems. So if you take the statistics and you take a look at what's happening in the United States, you can place that on developing countries and say that is what is happening, and it's going to happen at a faster pace than ever before. So what do we do? What does this tell us as we prepare to do medical missions? Well, we have to be thinking as we go about sustainability strategies. How do we help our partners become sustainable? How do we help them advance their clinical care? How do we really, it's coming, they're going to have older and older. We're going to talk about some statistics in a minute, but they're going to move from communicable diseases to chronic diseases. And most of all, how do we help them prepare patient care that includes compassion and proclamation? I'm not going to let us off the hook. Our goal here in medical missions is to use medicine as the platform for proclaiming the gospel. So we have to be thinking about how we work with our partners to achieve that. All of you in the room, you can be the change. You can be part of that. So what's our objectives today? Well, we're going to talk about I want to prepare you for going by talking about what are the realities on the ground. What kind of diseases, what are you going to be looking at? Secondly, we're going to then talk about some surveys that we have done about requests for help from a variety of countries: Malawi, Congo, Kenya, Haiti. We're going to summarize those in terms of what you can do to make an impact. And at the very end, I have a couple of paid political announcements, a couple slides just for you to think about as you go. So let's talk about the realities on the ground. If we get on a plane to go today and head for Africa, what are we going to see? Africa is the only region in the world where communicable diseases account for the majority of the disease burden, 70% versus 40% in the rest of the world. Okay, what does that mean? Let's unpack that. It means 70% of all the communicable diseases of what you see in Africa is communicable. That's like TB, HIV, AIDS, malaria, hepatitis B, and hepatitis C. We get on a plane and we head for a hospital. That's what we're going to see when we walk in the door. The leading causes of under 5 deaths are diarrhea, pneumonia and respiratory, malaria. I don't know what you do here in the United States. When you get on a plane and go there, that is what you're going to be seeing. You've got to be prepared for that. 1 in 4 children under 5 are underweight. Man, that makes all those children at even greater risks for everything. 25% of the children that you will see are still unvaccinated for things that vaccine preventable diseases. Simple things even like measles. 25% of the children that in these countries are still unvaccinated. Only 42% of public facilities have a complete stock of essential medicines. We'll see more about that in a minute. This is staggering. Counterfeit and substandard drugs are rampant. 20% of all the drugs in Ghana, and Ghana is the best, to 60%, 66% in Guinea. That means even the medicines that you might see might be counterfeit and or might be substandard. 60% of the total disease burden in the world of malaria is in Africa. 50% of the births are still unattended by a skilled person. Complications by pregnancy, you can read these. Africa represents the largest portion of under 5 deaths. 52% of the population, rural population, still do not have access to clean water, and 75% don't have access to improved sanitation. So what's this mean for us? If you're interested in going on a medical mission outside the United States, you have to be prepared for communicable diseases. You have to be prepared for childhood diseases like diarrhea, pneumonia, the respiratory things, the malaria. And what you're going to be seeing in pregnancy and childbirth is a lack of prenatal care and complications and lack of treatment protocols. So if you're going, these are the things you have to think about. Now, let's talk about the reality on the ground. I told you I'm a former hospital administrator. I like pictures and colors. So I have some handouts. You can see the details. Just look at the colors. So this is a survey we did of 20 primary care clinics in Malawi, in central Malawi last year. And I have 2 slides for you. The first one, this was speaking about equipment. So the good news is about half of those clinics had a glucometer. But that bad news is most of them didn't have the sticks to go with it. So this right here, see all the red? That's a simple otoscope for primary care exams. Most of those 20 clinics do not even have a simple otoscope. So this was a survey. You can see all the red boxes. This was a survey of just basic equipment that had to be in a primary care clinic. This is even worse, but you can still see the colors. This was in that survey. We looked at what drugs they had in stock, and you can see from the colors. For the most part, there's many things that they either did not stock or were out of stock. Something as simple as ampicillin. You can see the number of clinics that were that either didn't stock it or out of stock. Chloramphenicol. All of these things, which is a basic antibiotic. So what's the point to you? When we arrive in Malawi and we go to work in a primary care clinic, they may not have the drugs that you think are required and the things that you think you need or the patients need to be treated with. The next thing we did was we surveyed them and we did an evaluation of all those clinics, those 20 primary care clinics, in terms of their clinical care. We looked at 3 categories: safe babies, safe mothers, and nursing care. In safe babies, 0% were even had any training or were prepared to do neonatal resuscitation. They were all delivering babies, but 0% had the ability to resuscitate those babies. Only 15% had resuscitation equipment, and only 20% were doing an APGAR score on those babies. That's just a couple of the categories around safe babies. In the category of safe mothers, none of them, they're all delivering babies, none of them are doing a newborn physical. Only 20% of them were prepared to treat a postpartum hemorrhage. In a lot of cases, we found they had the drugs. These drugs that should have been refrigerated were simply sitting up on a shelf. And this is in central Malawi, where it gets hot out occasionally, which meant that even those that had the drugs, there was a question whether the drugs would do any good, even if administered. And only 30% of them, in this category, only 30% of these clinics had the vital signs equipment that a clinic should be equipped with. In terms of nursing care, we looked at that. Only 5% of these clinics, of these 20 clinics, were doing hand washing. So they weren't washing their hands between patients. 0% of them were prepared to start an IV line, and only 15% of them had proper sterilization equipment in the clinic itself. So where does that leave us? So we talked about Africa. Let's talk about Malawi specifically. The practical needs there, here's a short list of practical needs that were identified. Hand washing, IV lines in terms of storing labeled administration, sterilization, neonatal resuscitation, having the right equipment and ready to use, APGAR scoring, how do they score the babies after their birth, newborn physicals, postpartum hemorrhaging, and vital signs equipment. Having the basic equipment and having it ready and being prepared to use it. Now, what I will tell you is that those are primary care clinics in Malawi. As we visit all over Africa, you're going to see that same list of things. So as you are thinking about going someplace outside this country, that's an important list for you to think about and be prepared. So now we did a survey of hospitals. We looked at DR Congo, Kenya, and Malawi. And it was a combination of hospitals and nursing schools, and we went to the directors of nursing and said, what do you need most? What's at the top of your list in terms of continuing education that you can't satisfy? Number one on the list was nursing leadership. Came as nursing leadership, management, professionalism, included specific components like effective team leadership, professionalism and nursing ethics, the nursing process, medical, surgical, midwife conditions, and their nursing management. So that was the number one topic that directors of nursing in these countries came back to us with. Number two on the list was patient safety. Specific requests for help where they had continuing education needs that they couldn't satisfy was around patient safety and international safety goals. So they're struggling with, as we even do here in the United States, but at the top of their list was how do we do continuing education and training for our staff. Number three was infection control and prevention. Just back to hand washing. You think of that in those clinics. Those basic things are needed in hospitals as well. And these hospitals in these countries, the director of nursing is number 4. High on their list is quality assurance. Other various topics, so those consolidated were the top 4 most important topic areas for these hospitals. Other various topics that were noted and requested, basic life support, hemovigilance, which translates into blood transfusions, and how to do it and how to maintain it and the right processes. Alcoholism, palliative care, tuberculosis, laboratory, pharmacy basics, physical therapy. Also from the nursing schools, several of the nursing schools identified also that they're in the process of putting together BSN programs for nursing as well as midwifery. And one other listed request was a bachelor's degree in community health nursing. So these are the things that are going on within those hospitals. Let's take one other shot at this. Hôpital Sainte Croix is a hospital in Léogâne, Haiti. Went to them and said, give us your actual continuing education list for this year. And taking that list, which are the topics that you don't have the ability to do continuing education, you could use somebody to show up today to help you. 7 things at the top of their list: emergency care, CPR, ACLS training, in the emergency room, immobilization, restraint care and monitoring, nursing care of asthma patients, pain management, respiratory therapy basics, and nursing care of burn patients. Those were the 7 topics that they have slotted that they don't have somebody to come teach it. They don't have anybody on their staff that can teach it. For that hospital, the other things on their list, which is in the packet, pre-op nursing, OR nursing responsibility, post-op nursing, diabetes, integrated management of childhood diseases. If you know anything about ICMI, that's right at the top of the list. Blood transfusions, there it comes up again. Nursing standards of care for patients with tuberculosis, isolation, nosocomial infections, and cervical cancer. Updates on treatment protocols. So we've looked at the data. We've looked at the survey results. Let's bring it back to you. You're interested in going. Going to serve, I got bad news for you. This is back to the old cranky guy. I'm going to step on your toes. Going to serve is not about you. Going to serve is about the people you're going to serve. Okay? So in a primary care clinic setting, what does this all tell us? You need to understand communicable diseases. That's going to be front and center, and you've got to be prepared. Drugs. You've got to be prepared to know what they have and don't have, and many of the required drugs that you think that you're going to need aren't going to be there. Some might not even be available in the country. Now, editorial note. Do not load up your suitcase with what you want to take and take it with you. That's unethical. You can only use what is already in the country, what they already have in their formulary. So now if you want to take something, send them an email, get their formulary, and take some things that are on their formulary to make sure that you're taking something that satisfies them. And equipment. And if you haven't read Greg Seeger's book, When Healthcare Hurts, if you want to go, I'd recommend you go online. I think you can download it. I think Greg's got it as an ebook that you can download for free. But my recommendation is you go get a copy of Greg Seeger's book and read that before you go. Equipment. You've got to be prepared to know what is available, and some of what you think you need is not going to be there. Again, my editorial note. Please don't arrive and pass out free equipment. If you think about it, the process of doing that creates an ongoing process of dependency. They look at visiting teams and say, oh, they're going to solve our problems for us. You can't do that. You have to be in a mode of equipping them and helping them, remember back, to become sustainable. And the only way is equip them to solve their own problems. Last item, be prepared, if you're going to serve in a clinic, to serve basic clinic needs. So that list of 8 things that I gave you around the clinics, if you remember back in terms of basic things that we can train, take that with you and be prepared to train. Think about this. You go and treat, oh, you're a hero. You saw 400 patients in 1 week. Well, who's taking care of the 400 patients next week? And the week after that, and the week after that? It's much better that you're going and teaching some of the basic principles. You're going to see some patients, but in the course of that, you're teaching and improving their level of clinical care. You have to understand the WHO and IMCI standards and protocols. My recommendation, take a copy of that with you, because something's going to come up. You need it on your computer or on your phone or on some place that you can pull that out and say, oh, what is a standard and what should I do? So that was the clinic side. On the hospital side, again, it's the same, pretty much the same things. Understand communicable diseases, but you're going to need to understand the treatment protocols in those countries. But because I can tell you, treatment of malaria in Malawi is completely different than the treatment of malaria in the United States. And you need to be prepared for that. You need to be prepared for the childhood diseases. Be prepared because you're going to see these things. Be prepared for drugs and equipment like we've talked about. And most of all, you're going to see a hospital. Offer to be prepared to teach on the topics of continuing education. Any of those topics on the list in the handout, I can guarantee you, if you called tomorrow and said, I am coming on a trip next week, and I can teach on this, this, and this, the answer from the director of nursing there is going to be, hallelujah, how soon can you get here? Okay? Now, remember, so 2 more slides. These are my editorial slides. Remember, I'm the hospital administrator. I like pictures, simple guys. I get by with pictures. This is a picture I love. This picture talks about implementing tools. So if you take a tool and teach somebody how to use it, the time to do that is relatively short and very easy. Changing structures and systems, so it talks about skills is harder, staff and facilities is harder yet, structure and systems and roles is the hardest of all. I know you're all Americans and we can fix everything in the world. But what this tells us is we can't arrive and change everything in the 1 or 2 weeks that we're on site. Great picture, just to remind you as you go. The last one, it's in the handouts as well. It's what we've developed over a period of time from our own experience as well as from the experience of others. We're sort of called the axioms, sort of the basic principles. Number 1, my favorite, translation requires relationship. Anything you're going to do takes relationship over time to be effective. Wycliffe Bible translators. Everybody familiar with Wycliffe Bible translators? Their initial term in a country is 3 years, and in the initial term, you're not allowed to start translating. You're there for 3 years learning the culture, learning the language, before you even start thinking about translating the Bible. Got news for you. The same thing's true in medicine. You have to have that relationship before you can even start thinking about how to translate procedures and techniques from the United States. Number 2 on the list, culture trumps change. There was a report published by the Harvard Business Review a couple years ago that 75% of all the change projects in the United States failed to achieve their objectives. So the smartest, most well-equipped, richest countries and companies in the entire world are failing at change projects 75% of the time. Number 1 reason, they didn't think about the culture when they tried to make those changes. Same thing is true any place we go. I love this one, systems heal people, not projects. And the corollary to that is systems can also harm people. We have to be thinking about how we set up systems when we are working to change our international partners. Number 4, from famous guy, Sir Isaac Newton, second law of thermodynamics. You've probably all heard it. Any system left to itself will degenerate into a more disordered state. You can go and do something and you leave it and you walk away, what's going to happen? It's going to degenerate over time. And that goes back to translating and building systems. Brian Fikkert, who wrote When Helping Hurts, his axiom is avoid knowledge paternalism. Like, I have all the knowledge and I'm smarter than you. My simple correlation of that is you're not as smart as you think you are. Bob Lupton says, you can't serve someone out of poverty. You've got to equip them to do it on their own. Jim Collins says, in a chaotic world and chaotic and uncertain world, says greatness happens not by choice, or not by choice, not by chance. That we do that by equipping them. My good friend Greg Seeger says that medical missions can often be toxic. And finally, excellence in what we knew gives credibility and a platform to proclaim the gospel. Thank you for your time.